There's this idea that external beam radiation is an either-or thing. So you either do external beam radiation or you do something else. The important thing to know there is that external radiation can be used in conjunction with other things. So, for example, some patients who have surgery, a radical prostatectomy, are at some point afterward referred to us. And the reason they may be referred to us is because either there's this idea that maybe that individual needs or should talk about insurance-type radiation. So we use the word adjuvant when we're talking about that. So adjuvant means treatment given to try and reduce the risk that the cancer is going to come back, even though we think that the cancer has been completely removed, at least as far as we can see. And what will drive our thoughts about that will depend mostly on what was found in the report that was generated at the time of the radical prostatectomy, looking at things like whether there's cancer at the edge of what was removed. We call that a positive margin. So these are things that don't necessarily mean by any means 100% chance of recurrence, nor does it mean absolutely for sure somebody needs to have insurance treatment. So exactly what the risk of recurrence is depends on the particular combination of factors present in that situation. And the risk of recurrence could range anywhere, even if there is a risk feature of some sort in that prostatectomy report, as low as 5 to 10% up to 70 or 80%. So it really depends. And related to that then will be our thought about, what role insurance type post-radical prostatectomy radiation may have. The other scenario post-surgery that will come up is people will be sent back for what's called PSA relapse after the surgery. So what that means is surgery was done, they were followed for a time afterward, and the PSA became detectable and rose. So generally speaking, what that implies is that there's some cancer that has become apparent and is producing the PSA. Now, there are two ways in which cancer can come back that can lead to a rise in the PSA, bearing in mind that PSA will be produced by prostate cancer wherever it is. So obviously the one we don't want to think about is prostate cancer that is spread. The other will be prostate cancer that has recurred where the prostate used to be, and that is in the prostate bed. So it's sometimes hard to know which it is, but there are various things we can look at to give us a sense of which it might be. And basically, one of the clues will be how quickly the PSA is rising. But in any case, we can give radiation, if we think it's a localized thing, so PSA relapse, where we think it's just in the prostate bed, and that'll be another reason why we may give radiation after surgery. Now, another example of where external beam radiation is combined with something else is we quite commonly, for higher risk prostate cancer, combine it with hormone therapy, androgen withdrawal therapy, known by different terms. A third example of how we combine external beam radiation with other things these days is we will sometimes give hormone therapy and some external beam radiation therapy, then a brachytherapy boost after. The brachytherapy boost being a way of making sure we give a little bit more radiation therapy than we ever could with external beam radiation therapy alone. And there is some evidence that helps at least some men do better. And again, exactly where these different approaches fit depends on the details of that particular man's particular case.